Good evening, everyone. Thanks, everyone, for attending this session, number 2, and 2 consecutive day on headache updates. Today's talk would be on how to avoid headache in Ramadan for people who have headache or for people who don't have headache as well. The first session would be didactic lecture done by Dr. Deeb Kayed, who's consultant neurologist in Mediclinic Hospital, and he has his own private clinic as well. He is also assistant professor in MBRU. The first half an hour would be mainly didactic talk, followed by questionnaires held by you guys, or we can communicate or discuss cases together. Session number 2 would be done by Dr. Yusri, and would be mainly on clinical cases on management of migraine.
Good evening, everybody. Thank you for asking me to give a talk about managing headaches during Ramadan. I would like to thank the organizing committee of the Emirates Neurology Society, as well as our sponsors today, Novartis, for giving me this opportunity. Here are my disclosures. The outline of the talk today will be as follows. We will address the benefits of fasting. This will be a clinically oriented talk, not much basic science, I hope. We'll be talking about fasting and headaches in general, the role of caffeine, Ramadan specifically, and headache studies, the management of headaches in Ramadan, including Cgrp-Based Therapy, and then some concluding remarks. So as far as benefits of fasting, there have been documented benefits in multiple studies and reviews about weight loss and loss of fat, about greater circulating levels of HDL, cholesterol, and reductions in blood pressure, as well as reductions in circulating levels of LDL cholesterol and total cholesterol and glucose. These were observed in both healthy participants as well as those with chronic illnesses, and were much more evident in males with metabolic syndrome. Mixed results have been seen in people with type 2 diabetes as far as the lipid profile changes. This is all I'm really going to say about the benefits of fasting. There's so much research on this topic, but I don't think it's clinically relevant. So let's talk about in general about fasting and headaches. We go back to our source, which is the International Classification of Headache Disorders, the 3rd edition of which came out in January of 2018. And as you know, this classifies headaches into either primary headaches, secondary headaches, or neuropathies and facial pain and other headaches. Primary headaches, of course, comprise a good 85% of all headaches, 80, 85, maybe even 90% of all headaches. Only 10% are secondary headaches. And in those secondary headaches, category number 10 is headache attributed to a disorder of homeostasis. If we look at headaches attributed to disorders of homeostasis, we see blood pressure abnormalities, thyroid abnormalities, dialysis, hypoxia, and hypercapnia, and we also see a subcategory devoted specifically to headaches attributed to fasting. And in this category, this is how we diagnose headache attributed to fasting. It is usually a diffuse headache, not fulfilling the criteria for migraine or any of its types, but fulfilling the following criteria. There has to be a fast for greater than 8 hours, and there is evidence of causation demonstrated by both of the following points. Headache has developed during fasting and has significantly improved after eating, and not better accounted for by another diagnosis. So fasting for 4 hours, if you get a headache, that's not really headache attributed to fasting. I'm not really sure where they came up with the 8 hours, but in prior editions of the International Classification of Headache Disorders, it used to say a longer period of time, like 12 hours or 14 hours, if I'm not mistaken. But in this edition, they brought it down to 8 hours. The headache that's attributed to fasting is, if you like, more tension-like. It is diffuse, non-pulsating, and mild to moderate in severity. If you do get a headache that's more migraine-like, it should be classified as a migraine headache precipitated or triggered by fasting rather than being a fasting headache. And headache attributed to fasting is significantly more common in people with a prior history of a primary headache disorder. So the likelihood of headache developing increases as the duration of the fast increases. But 8 hours is the cutoff for the diagnostic purposes. And it does not appear to be related to duration of sleep, withdrawal from caffeine, or hypoglycemia, although these may be contributing factors. So specifically with hypoglycemia, I mean, people naturally think, all right, I'm fasting, my blood sugar is dropping, that's why I'm getting the headache. But we know from multiple studies that that's not really the case. Headache attributed to fasting can occur in the absence of hypoglycemia. Insulin-induced hypoglycemia does not precipitate headaches in migraine sufferers. And headache is not a complaint of patients presenting to the emergency room department with symptomatic hypoglycemia. And therefore, hypoglycemia is not really the mechanism of headache in fasting. Okay, what is the role of caffeine? What about caffeine? Well, let's look at the caffeine content of some of the commonly consumed caffeinated beverages. If you look at brewed black tea, 47 milligrams of caffeine. Brewed green tea, 28 milligrams of caffeine. If we look at decaffeinated black tea, it's only 2 milligrams of caffeine. Look on the right-hand side for coffee drinks. Brewed coffee has 96 milligrams of caffeine. Espresso has 64 milligrams. Instant decaf, 2 milligrams. If you go to one of the chains, Costa, for example, and you order a large coffee, whatever it is, a latte, you may get over 200 milligrams of caffeine in one drink. So these are significant sources of caffeine. If we look at others, sodas and energy drinks, like Red Bull, Power Horse, and so forth, again, they have their own levels of caffeine in them. If you look at carbonated beverages, diet or non-diet, again, they've got caffeine. But the clear ones, such as 7-Up or Sprite, are usually caffeine-free, as are most brands of root beer. And let's not forget medications. And I had to use the brand names here just to make it easy for people to recognize what we're talking about. It seems that 65 milligrams is a magic number. I'm not sure how that came around either. So Panadol Extra or Panadol Migraine are actually identical in their amount of caffeine, 65 milligrams. Panadol Extra is simply paracetamol plus caffeine, whereas Panadol Migraine has an additional aspirin in there. Excedrin Extra Strength has the American equivalent of paracetamol, which is Tylenol, which is acetaminophen. Again, interestingly, Excedrin Extra Strength or Excedrin Migraine are exactly the same composition. They're just marketed under different names with the exact same number of milligrams. Excedrin Tension Headache even has caffeine in it, but no aspirin. Maxigesic has no caffeine in it. So that's a local product that has been introduced here in the UAE, at least for some time now, has no caffeine in it. Furoset, we don't have access to it here, which is good actually, because butalbital is not a good way to treat headaches. Solpadeine, however, is available here, and solpadeine includes paracetamol plus codeine and caffeine. It has about 30 milligrams. So we should not forget all these other sources of caffeine with or without opioid analgesics. Okay, so now we have an idea of what caffeine is. How is caffeine related to headache? Well, caffeine is related to headache under the secondary headaches, under headache attributed to a substance or its withdrawal. So again, in this regard, it's caffeine withdrawal headache that we're thinking about rather than caffeine as being a trigger. I think it's very, very rare, at least in my experience, that caffeine is the trigger for migraine, although it can happen. Usually it's caffeine withdrawal that triggers headaches or migraines or whatever it is. So if we look at this category, you can have headache attributed to use of or exposure to a substance. We all are familiar with medication overuse headache and how it complicates migraine, for example. And then we have headache attributed to substance withdrawal, including opioids, estrogens, many other things, but definitely caffeine. What are the diagnostic criteria for caffeine withdrawal headache? Well, you need to be using caffeine for at least a couple of weeks, at least at a dose of 200 milligrams per day. So it's headache developing within 24 hours after regular consumption of caffeine in excess of 200 milligrams per day for more than 2 weeks, which has been interrupted. So you've been drinking caffeine, 200 milligrams per day or more for at least 2 weeks, and suddenly you interrupt it. So interruption doesn't mean stop. You may just reduce. For example, you drink coffee a lot at work or tea a lot at work. every day, then come the weekend, you're at home, you don't, that's a drop in the amount of caffeine you take, you can have a withdrawal headache, whether or not you have an underlying headache disorder. Usually, caffeine withdrawal is a simple thing to deal with. It usually resolves by itself within a maximum of 7 days, as long as you don't consume anymore. And these are the diagnostic criteria. Headache is relieved within 1 hour by intake of caffeine. So we all have seen these patients, right? They got headache, they come in, they take Panadol Extra, and their headache is gone. And then you take further history, you find out they're drinking 10 cups of coffee and tea and God knows what else every day. And it's really caffeine withdrawal. And it's not the paracetamol that's taking away their headache, but the caffeine that's doing so. There is not much ambiguity about the role of caffeine in migraine unless you don't understand the role of caffeine in migraine. So some people have argued that caffeine may not be a real headache trigger, but more of a premonitory symptom as well. They looked in this one review in Nutrients 2020 at 21 studies investigating the prevalence of caffeine and caffeine withdrawal as a migraine trigger, and 7 studies evaluating caffeine in acute migraine treatment. Well, the conclusion is it's only a small percentage of participants in which caffeine was a migraine trigger, ranging, depending on the study you look at, from 2 to 30%. And most other studies, if not all other studies, found that caffeine is safe and effective as an adjunct analgesic to whatever else you're using in relieving headaches. So there's insufficient evidence to recommend ceasing consumption of caffeinated products. I usually tell my patients that 1 to 2 drinks, caffeinated beverages a day is okay. Basically try to stay below that 200 milligrams per day threshold that seems to be related to caffeine withdrawal and headache. Again, I'm not sure where the 200 milligrams came from. It must be from studies showing that consuming less than 200 milligrams a day does not lead to dependence and therefore withdrawal thereafter. And if patients wish to continue drinking caffeinated beverages, they should keep their daily intake as consistent as possible to avoid withdrawal headache effects. Okay, we next will look at Ramadan and headache studies. Perhaps the best quoted study in the literature is the first of Ramadan headache study from Saudi Arabia, published in 1999. Again, in this study, they wanted to look at the frequency of headaches on the first day of Ramadan. So they sent 150 copies of a questionnaire to hospital staff, a random sample of hospital staff, and about 77% of these individuals completed the questionnaire. So 116 individuals responded. 91 of those individuals fasted, whereas 25 did not, for whatever reason. And you can see that in the fasting group, 41% developed some sort of headache on the first day of Ramadan, compared to only 8% in the non-fasting group. A statistically significant difference at the p-value of 0.002, and the headache in 78% of the cases was tension type in character. The headache frequency increased with the duration of fasting, and affected, as we had mentioned earlier, those mostly prone to having headaches. Caffeine withdrawal seemed to play a role in this study, but other factors such as lack of sleep, hypoglycemia, and dehydration were not definitively a cause, although there may have been some contribution in a small number of cases. And they suggested in this study that a progressive reduction of caffeine consumption in the weeks preceding the month of Ramadan and a cup of strong coffee just before the start of the fast in the morning may prevent the occurrence of first of Ramadan headaches. A second study conducted in Palestine and published in 2012 looked at the prophylactic effect of Ethioreximab in preventing the first of Ramadan headache. It was a placebo-controlled, double-blind, and randomized trial. The reason for using Ethioreximab is that it has been used in the fasting, which is practiced in Judaism, called the Yom Kippur fasting, which is a 24-hour fast, and it seemed to be effective. And therefore, it was tried for the Ramadan fasting. Again, this was a double-blind, randomized, prospective crossover trial of Ethioreximab, Arcoxia, 90 milligrams, versus placebo, taken just prior to onset of fasting during the first 2 weeks of Ramadan. So every morning, just before fasting for 2 weeks, take that. It was in healthy adults aged 18 to 65. All demographic and baseline data was collected, and the character of the headache was described in detail for all patients. 222 patients were enrolled, 87% responded. Ethioreximab, a COX-2 inhibitor, reduced the incidence of first of Ramadan headache by 54%. So there was a 46% incidence in the placebo group compared to only a 21% incidence in the Ethioreximab group on the first of Ramadan. So they looked at headaches on the first of Ramadan, and then they looked at headaches on days 1 through 6. And again, in the placebo group, the reduction in days was 1.6. Sorry, the mean number of headache days were 1.6, whereas in the treatment group, it was 0.86, again, statistically significant. The median severity of the headache in the treatment group was significantly lower as well. And in the second week, remember this was a 2-week study, they didn't find a big difference between those who did or did not ingest Ethioreximab. The conclusion of the study was that Ethioreximab 90 milligram taken prior to a 15-hour ritual fast of Ramadan, because at that time, I think it was in the summertime, it was published in April, but the study itself was in the summertime. It was a longer fast. It was a 15-hour fast. Ethioreximab reduced the incidence of and attenuated headaches during the first 5 days of Ramadan. This is personal communication from my colleague in Kuwait, Dr. Jassim Al-Hashil, one of the headache experts in the area. This is have been submitted for publication, but he was kind enough to share this data with me about the impact of Ramadan fasting on migraine headaches. And if we look to the graph on the left, to the pie chart on the left, we can see that 62% of the patients fasting, patients with migraine who were fasting, were able to continue fasting the entire month without a problem. Whereas about 30% had to break their fast between 1 to 3 days, and about 2% were not able to fast the entire month of Ramadan due to their migraines. And if we look on the right side pie chart, we see that 75% of patients with migraine felt that the migraines during Ramadan interfered with their daily activities. Again, also, we looked at the number of migraine days during Ramadan compared to the month of Sha'ban. And the month of Sha'ban is the month preceding Ramadan, which is Ramadan is the ninth month in the lunar calendar, whereas Sha'ban is the 8th month. So on average, patients had 6.9 headache days in the month of Sha'ban, shown in orange on the left-hand side, compared to 10.42 days shown in yellow during the month of Ramadan. It makes sense that the more headaches you have, the more analgesics you use. And again, if they compared patients with migraine analgesic use in the month of Sha'ban preceding fasting and the month of Ramadan during fasting, there was a big difference there as well. There was not much of a difference in the severity of pain when it happened. Next, we will go to management of headaches in Ramadan. If we look at the top 10 migraine triggers, as published by the American Headache Foundation, we see that a lot of them are affected in Ramadan: dehydration, diet, caffeine, and sleep schedule. And therefore, if we want to strategize in Ramadan to reduce the impact of headache, patients are advised to have an adequate suhoor, which is the meal just before sunrise, to have adequate sleep, to have enough hydration during the non-fasting hours, to reduce caffeine intake prior to Ramadan gradually. Perhaps in some patients to have a cup of coffee at suhoor, that might help. And as with the study with Ethioreximab, it may be helpful to use a morning long-acting COX-2 non-steroidal anti-inflammatory drug. But what to do if you get a migraine? So you've done all this stuff and you still have a migraine. Well, you can employ non-pharmacological relaxation techniques, meditation, mindfulness, yoga. All these things have proven to be of some benefit for patients who perhaps don't want to use medications or prefer not to use medications. Pregnant women sometimes don't want to use medications, and these may be options for them as well, whether or not they're fasting. Now, as far as acute therapy, according to the official Fatwa Center in the UAE, the General Authority of Islamic Affairs and Endowments, medications taken in ways other than through the mouth do not break the fast. And that's important to know. So this means that injections or tablets inserted in other parts of the body are permitted during the fast. But an injection that is taken with a nutritious purpose, so hanging intravenous fluids for rehydration, that would break the fast. What can you use as acute therapy pharmacologically? Well, we have to use a non-oral route and a non-intranasal route, because some of the intranasal medications will go down the back of the throat. Well, the most obvious is the rectal route. And for that, we have diclofenac suppositories, 100 milligrams, which I often use as rescue therapy. But there are also suppositories of antiemetics, such as metoclopramide and prochlorperazine, which is Temitol or Compazine. The topical route is not really very effective. We don't have topically effective medications, at least not in the UAE. The subcutaneous route is probably the most effective. Sumatriptan is one of the most effective treatments for migraine. And of course, IV and IM routes for non-steroidal anti-inflammatory and antiemetics and narcotic analgesics can be utilized. Nerve blocks can be helpful, greater occipital nerve blocks, probably not sphenopalatine ganglion blocks. Non-invasive neurostimulation, transcranial magnetic stimulation for migraine with aura, but that country unfortunately has gone out of business, is bankrupt, so I don't know that we can get hold of these things. Transcutaneous supraorbital stimulation, such as the Cephaly device, and vagal nerve stimulation. Oxygen therapy, of course, is useful or might be useful in patients with cluster headache. How about preventive therapy? Well, we should not really mess with preventive therapy prior to the start of Ramadan. We should optimize it before Ramadan starts. Once daily oral medications are preferable to more frequent dosing. And botulinum toxin, if indicated, is an option, but again, this should be optimized before Ramadan starts. And the same applies for Cgrp-based therapy. I'd like to take a side here and just say a few words about Cgrp-based therapy because it really has revolutionized the treatment of migraine. Just like the triptans revolutionized the treatment of migraine in the mid-1990s, acute migraine, Cgrp-based therapy now has revolutionized preventive therapy. And of course, the first Cgrp-based therapy to be approved was Erenumab, which is Aimovig, and it has been used in nearly 500,000 patients worldwide. And we've used it definitely here in the UAE, and myself and my colleagues in the department and many other physicians around the UAE and in the Gulf region now where this medication is available have had the opportunity to use it and see its wonderful effects of this whole group of medications as a whole in prevention. It comes in 2 doses, 70 and 140. It says very soon in the UAE. Well, about a month ago, it has arrived here in the UAE. And the beautiful thing is that it is the same cost. 70 or 140 comes at the same cost. I'm not going to go through the data for Erenumab or Aimovig because it's been well established, but I'll go through this one study quite quickly, which looked at patients who have already failed 2 to 4 prior preventives. And this study, the Liberty study, looked at patients in a double-blind treatment phase followed by an open-label extension phase. Needless to say, patients did well. If we look at the left-hand side of the graph, the proportion of patients with a responder rate of greater than 50% in the treatment group was significantly higher than the patients in the placebo group. And if we look at the results in the middle and to the right at the open label extension phase year 1 and the open label extension phase year 2, we again see during this open label phase, everybody was switched over to the 140 milligram Erenumab dose. We can see sustained efficacy and benefit over the years. It's not only efficacious, but there are really no red flags or bothersome side effects that we need to worry about. The ones reported in the study were nasopharyngitis, back pain, influenza, and sinusitis. Not much higher than what is seen in the placebo group. And if we want to look at the long-term safety of the longest studies anti-CGRP agent, we can see that injection site reactions are the most common reportedly, the most commonly reported adverse effects. Constipation was also seen, and it was higher at the higher dose of 140 milligrams. And other patients may have reported some muscle spasms or myofascial type symptoms or pruritus, but that's in a very small percentage of people, not really exceeding 2%. And therefore, 4.5-year data shows us good efficacy and safety of this medication. So to conclude for Ramadan, and I meant for this talk to be short in order to give everybody a chance to ask questions so that we could learn from each other and perhaps explore some of these things we talked about a little bit more. planning for Ramadan is paramount. We need to plan prior to the month of Ramadan, what to do during the month, especially the early days, and how to handle acute attacks so people do not suffer needlessly and avoid taking medications needlessly. Thank you for allowing me to participate this information about managing headaches in Ramadan, and I'm happy to take any questions you have.
Okay, we're gonna start. Thank you very much, Dr. Kayed. We're gonna start now with questions and answers from publics, and I made few questions here. One of the question is can overeating prevent from headache?
I'm not sure exactly what overeating means, but one of the recommendations is that people have a good suhoor. You know, people who are prone to headaches, if they are stressed by anything, so stress comes from fasting, comes from not sleeping right, comes from emotional distress or so, any change, the brain of a patient with migraine is sensitive to change. So any kind of stressor has the chance of triggering migraines. So fasting and not eating has the chance of triggering migraines. And therefore, we advise patients to have an adequate suhoor, a healthy suhoor, so that the fasting will become easier. Overeating, I don't know if there is any data about overeating, but if I have to guess, it might actually worsen headaches. I don't know, but I don't have any data about this. Do you, Dr. Abubaker, do you have any information about this?
I'm not sure, because I know that people in Ramadan, they have tendency to eat sweet a lot. So probably sweet one is one of the provoking factor for migraine. One of the habits which we need to avoid is overeating sweet, probably. If you want to eat or overeat, maybe you should divide the meal in three or four portions over the course of 8 or 9 hours. That's what I think. Another question is, I take Topamax twice a day. How do I divide this during Ramadan?
So topiramate, of course, is approved for epilepsy as twice-a-day type medications. But in headache medicine, actually once-a-day dosing is sufficient. So although we titrate slowly, 25 milligrams once a day for a week, and then twice BID for another week, and then 25 in the morning, 50 in the evening for a week, and then we end up with 50 BID, as long as the patient tolerates it, I usually change from 50 BID to 100 once daily, whether at suhoor or at iftar. So once daily seems to be adequate for headache. Now, if you prepare it twice daily for whatever reason, just take it with suhoor and iftar.
Okay. And I think the other medication will apply the same as well, like Inderal and Triptizol, Dipykine. You can apply once a day dose. Another question here, is Ethioreximab effective for migraine and other headaches as well?
So Ethioreximab is Arcoxia. It's a COX-2 inhibitor, non-steroidal anti-inflammatory. So we know that for acute pain relief, migraine or tension headache or otherwise, we can use non-steroidal anti-inflammatory drugs, whether it's ibuprofen or diclofenac or naproxen or whatever it is. So Ethioreximab is also another option, whether or not it's not specific for fasting. So yes, it can be used.
One of the questions here, is constipation a cause for migraine headache?
The gut-brain connection. You know, we get lots of patients with migraine who tell us that when their gut is out of control or when they're constipated, their headaches are worse. We know that among patients with migraine, the incidence of irritable bowel syndrome is a little bit higher than in the general population. So there is a connection over there. I'm not sure, what to do about it, except to try and handle both conditions together. So for people, for example, with irritable bowel syndrome and migraines, and I've had this success on multiple occasions, I like to use amitriptyline because it can address both. Of course, amitriptyline can worsen constipation. So you got to watch out that it's not irritable bowel syndrome with constipation rather than diarrhea. If there is constipation, then you just work on it by using whatever you need to use, Movicol, Ediolax, whatever agents you need to optimize bowel habits. There is a connection. What the exact connection is, I don't know.
I guess this question you already answered. What's the most effective treatment for migraine?
Well, I don't know if you mean decapitation. If you lose your head and you have no head, you will no longer have migraines, but that's not an optimal solution. So it depends whether you mean acute treatment or whether you mean preventive treatment. I think if we talk about preventive treatments, a general rule is that with preventive treatment, you can reduce headaches by 50% in about 50% of the people. That actually even applies to the newer medications. The big attraction of the newer medications is speed of onset of action and really little to no side effects. If you're talking about acute therapies, of course, to date, the best acute therapies are triptans. But we know that 20% of patients may not respond to triptans altogether, and about 30 to 40% of patients may have an inadequate response or have intolerable effects from triptans.
The same guy is asking the amitriptyline dose in patients with migraine and constipation.
Migraine and constipation. Well, it can cause constipation. It doesn't have to cause constipation, but it may cause constipation. But if you want to use amitriptyline in migraine or irritable bowel syndrome, we usually start low and go slow. So you could start at 12.5 or 10 milligrams at bedtime, go up to 25. And if need be, you can go up to 50 and 75. You know, when psychiatrists used it for the treatment of depression, they used doses from 100 to 150 milligrams. Now, when we use it for neuropathic pain or for migraine or for irritable bowel syndrome, lower dosages seem to be helpful. And when the higher dosages, a significant number of patients are not able to tolerate the sedating side effects or other side effects.
One of the audience is asking, is migraine threatening?
Is migraine what?
Is it threatening or is it life-threatening? That's what they mean, I believe.
Okay, so migraine is not a life-threatening condition, but it can really mess up your life and reduce your quality of life, and it can be quite burdensome. You know, if you look at the World Health Organization and the number of years lived with disability, migraine ranks up there among the top 4 or top 5, or even the second in the years lost to disability all around the world. So it's a disabling condition, but not usually a life-threatening condition. If you have migraine with aura, your risk of stroke is slightly higher than the general population or than migraine without aura. So in that sense, it might, but otherwise, no, it's not a life-threatening condition.
One of the questionnaires asking, I have medication overuse headache, and I tend to use medicine every day before Ramadan. So what should I do during Ramadan?
Well, the question is, are you on adequate prevention? There's no way to address medication overuse headache at Ramadan. It's just not possible. This is the wrong time to address it. It's very difficult to address, and there's a lot that needs to be done, but this needs to be done way before Ramadan starts. So the answer to that is to optimize migraine prevention. And one of the ways you can optimize migraine prevention is by using Cgrp-based therapy or other therapies. And but Ramadan is not the time to be thinking about this.
Okay. One of the questions by Dr. Nahed, what about the new trends in screening migraine?
If you tell me what the new trends are, I can comment about them. What do you mean by the new trends of screening migraine?
I believe she meant if there is any new test you do to diagnose migraine, which I believe there is no.
Yeah, migraine is basically, as far as I know, migraine is diagnosed by the International Classification of Headache Disorders classification scheme. If you fulfill the criteria, you've got migraine. If you don't, then you don't. Now, as far as screening, there's a very old screening tool called the ID migraine. And the ID migraine basically, which you can have in the waiting area of the GP or the family practitioner, has 3 questions. If you have a headache, is it throbbing? Do you have nausea? And do you have light sensitivity? Do you have throbbing? Do you have nausea? And have you missed any work or anything like this? If you have 2 of the 3, then there's a high chance of you having migraine, and that would prompt referral to a headache specialist or to the family practitioner to ask more questions to understand whether or not the patient has migraine.
Okay.
Are you familiar, Dr. Abubaker, with any other screening tools being used for migraine?
No, I usually use the international headache criteria, which is a classical one. If the question is meant, if there's any test you can do to diagnose migraine, there is no test you can do. It's it's a clinical diagnosis based on history taking and ruling out other diseases. So if you have symptoms suggestive of migraine plus normal physical exam, I think you go ahead and treat the migraine. Does high blood pressure cause headache? Of course, yes. Do you have any other answer, Dr. Kayed?
Yes. I mean, no, I don't have another answer. And yes, high blood pressure can cause migraine. But please understand this. Hypertension is called the silent killer. So please don't wait until you have headache to say you've got high blood pressure. So why is it that some people with high blood pressure develop headaches and some people don't? I don't know. But don't wait for headache to diagnose high blood pressure as a sign.
So there's a misunderstanding that younger people don't get migraines. So one of the audience is asking, can migraine occur in children?
Of course it does. I mean, the peak incidence of migraines is in the 20s, 30s, and the peak prevalence is in the 40s. But we all have children, teenagers, children as old as 6, 7, 8 with migraines. There are reports in the literature for kids at age 2 and 3, and I don't really know how they get that history. It must be very difficult to decide whether they have aura or don't have aura, but usually you get these in kids with periodic syndromes like cyclic vomiting or torticollis. It's a migraine equivalent. And how do we know that this is migraine? Because we know in families, and as these kids grow up and get bigger, they start having regular migraine. And they used to have episodes of vomiting or episodes of vertigo or episodes of neck turning, torticollis. And nobody understands what these are. And these episodes would last half a day, 1 day, 2 days, and will come intermittently. And these are recognized as periodic syndromes, and they are part of the International Classification of Headache Disorders, and they are a migraine variant, basically. So yes, it affects children. I see many children with migraine.
One of the audience asking, is there a difference between migraine and vertigo, and do they connect together?
So migraine is migraine is migraine, mostly with headache, but it can be isolated migraine aura. Vertigo is a false sense of movement, most often caused by an inner ear problem, peripheral vertigo, but it could be central as well. These are 2 separate conditions. However, we know from genetic studies that patients with migraine, that in the same families, you can have other people that have perhaps motion sickness, or they can have a tendency to have vertigo. And in some patients, you can have both migraine as well as motion sickness. And of course, in the addendum to the, or the appendix to the International Classification of Headache Disorder, there is migraine-related vertigo or vertiginous migraine, or it has many different names. Experts have not yet agreed on the criteria, although we all in our clinics see patients with migraines complaining of dizziness, and that's very common, especially when the migraine is more severe. But sometimes also there are patients who are having vertigo, and the vertigo spells come as attacks, fulfilling criteria for migrainous vertigo, and you treat it the same way you treat migraine, and you will get some improvement. So yes, there is a link there. It's not well understood, but we all see it in our clinical practice, and we just treat it as migraine.
One is asking, many women experience migraine during menstrual cycle. Can we reduce or eliminate the severity of it without medication?
So you would treat menstrual migraine the same way you treat non-menstrual migraine, with the same kind of medications and the same kind of approach. However, sometimes if there is, specifically for menstrual migraine, there may be a role for hormonal therapy. oral contraceptive pill taken continuously, for example, or something of the like. But usually we treat them with the same medications that we treat non-menstrually related migraine. Again, in the International Classification of Headache Disorders, there's no differentiation or distinction between migraine and menstrual migraine. Whereas in the appendix, and the appendix is usually a place where they put certain migraine diagnoses with proposed criteria, and people are advocating for it to be included in the official version of the classification. But experts or the data is not yet there to determine 100% the validity of the diagnosis. So in the appendix, there is menstrually related migraine and pure menstrual migraine. Pure menstrual migraine means the migraine attacks happen only around the time of menses, whereas menstrually related migraine, which is most of our patients, the women get migraines anytime during their cycle, but also during at least 2 out of 3 cycles. And sometimes, often in the women, the headaches that are associated with menses are more severe than those not associated with menses.
I get motion sickness with migraine. Would amitriptyline be effective?
As a preventive, it may or may not be. Yes, there are other medications that may be helpful for migraine that has a balance disorder or dizziness or vertigo with it. One of them is flunarizine, Sibelium, for example, that may be effective in such cases. But any migraine preventive, if you are able to reduce the incidence of migraine, you will get also rid of, hopefully, of the associated motion sickness or whatever.
Okay, Dr. Kayed, any advice for pregnant women who get migraine during Ramadan?
Yeah, don't fast. Don't fast and take whatever medication you need to do. I mean, our religion is a religion of ease, right? Of practicality. If you are pregnant, maybe it's not the wisest thing to do to fast during Ramadan.
Okay, if I want to fast though, what should I do?
Well, then you need to follow all the things that we mentioned, which is have an adequate suhoor, be adequately hydrated. There are many medications that are allowed during Ramadan. Use non-pharmacological interventions such as biofeedback, relaxation, yoga. Triptans are not contraindicated during pregnancy. Non-steroidal anti-inflammatory drugs are not contraindicated in the second trimester of pregnancy. So there are several medications. Antiemetic drugs can be used during pregnancy. So we have certain medications that can be used. Now, if the migraine is severe enough, then maybe this is not the year to be fasting.
Can I use botulinum toxin in pregnancy?
Okay, well, according to the label, you cannot. I have not had the chance to use it, but there are many botulinum centers around, botulinum toxin centers around there. I wouldn't start it in pregnancy, but if the patient has been on it and it's stable, most experts agree that there will be no harmful effects from botulinum toxin, but you would have to get the consent of the patient.
Can I use paracetamol along with domperidone for migraine?
You can, of course, why not?
Domperidone is one of the antiemetics, which is
Motilium,
usually used. I have crave for sweet, and during Ramadan, my crave for sweet increases and I have increased tendency of migraine headache. How can I solve this one?
The question is, the craving for sweet, is this a premonitory symptom? Migraine is not just a migraine attack with or without the aura. There is a prodrome and a postdrome. And in the prodrome, there could be cravings for foods, including sweets. And that craving might be part of the migraine because the initial migraine pathophysiology may involve hypothalamic stimulation in the brain. And hypothalamic stimulation in this area can result in cravings and certain processes which we don't fully understand. And it's not that the sweets is triggering the migraine, but the migraine itself is causing a craving for sweets, after which you get the migraine. So the way to do that, if the migraines are frequent enough, is to institute adequate preventive therapy. If not, whenever you get the migraine, is to treat it as early as possible with the best effective medications.
I take the injection in daytime. Can I take it during Ramadan after fasting, or can I take it in daytime?
I don't know what injection they're talking about, but as per the fatwa from the UAE Fatwa Center, I guess that's what it's called, injections does not break the fast. So take it whenever you like.
I believe they mean one of those monoclonal antibodies.
Yeah, I mean, it's once a month. So you can, daytime, evening time, doesn't matter.